Good afternoon, everyone, and welcome to one and all. Vision 2020 India, in technical collaboration with OCI and in association with Cybersite Orbis, is conducting a series of webinar on different optometry topics. So this is our second session in the series in the clinical examination tools. We are covering today retinal evaluation. So today I have the privilege of welcoming Dr. Prema Chande, a renowned leader in the field of optometry, who has achieved great success in the field and has significantly contributed to the community and society. She has completed her Bachelor's of Optometry from prestigious Elite School of Optometry in 1992 and Master's from Lotus College of Optometry in 2010. She is a Fellow of IACL since 2005 and Fellow of American Academy of Optometry since 2019. She completed her PhD from Chitkara University in 2021. She is a recipient of many national and international awards, naming few like Drivisa Award, Best Optometrist of the Year Award, Contact Lens Educator of the Year Award, Asia Pacific. She is currently heading Lotus College of Optometry, Treasurer and Board Member for ASCO India, and she is a Standing Committee Member for Public Health at the World Council of Optometry. She's the Director of Optometry Council of India and Task Force Committee Member in proposed Allied and Healthcare Council, Ministry of Health and Family Welfare. I was fortunate enough to get a teacher and mentor like her. Welcome, Prema ma'am. Joining us today in panel discussion, we have Mr. Ajay Shinde. Ajay sir is an experienced and renowned optometrist running his successful private practice in Bangalore for about the past 30 years, named as Shinde Eye Care. He graduated from prestigious Elite School of Optometry. He is a key opinion leader for many ophthalmic and contact lens companies. His area of specialization include ophthalmic dispensing, contact lens, vision therapy, and orthokeratology. Welcome, Ajay sir. Joining him today, we have Mr. Kunal Shah in the panel. Kunal sir graduated from Birla Institute of Technology and Science, Pilani, India. He serves as a guest faculty at Manipal University, facilitator for India Vision Institute, and he is a key opinion leader for Alcon. He is running his private practice successfully in Hubli, named as Eye Savers, since many years. Welcome, Kunal sir. So without wasting much time, I would like to invite Prema ma'am to give a talk on retinal evaluation. Welcome, Prema ma'am. Over to you. Yeah.
So I understand I have 30 minutes to cover this. It's a fairly extensive topic. So I'll try my best to do some justice over the next 30 minutes. So basically, why we are even talking of doing a retinal evaluation. So largely, when you consider optometrist, we are, labeled as primary eye care practitioners. And when it comes to primary eye care, largely the concept is only about doing vision and refractions. But for me, primary eye care is something which will stop people from going blind as a first line of defense. And the reason why retinal evaluation is important is largely when you look at retinal conditions, they are asymptomatic. These are considered silent killers. So patient is not going to come to you saying, I've got early signs of glaucoma in my eye, right? And initially the vision is not affected. And you have a lot of other systemic conditions like diabetes, hypertension, and so on that also affect the eye. And early detection is the key to prevent these conditions from damaging the eye permanently. So that's the reason why a retinal evaluation is extremely important. If you look at the leading causes of blindness, cataract and refractive errors, although put on top of the list, these are very, very treatable conditions, manageable conditions. But when you look at the other leading causes of blindness, they all evolve around retinal conditions like glaucoma, diabetic retinopathy, and age-related macular degeneration. So what are the tools and techniques? How can you go about doing a good retinal evaluation? So you have a lot of options today. You begin with looking at the central retina, where you can just use a simple direct ophthalmoscope to do it. We have a whole range of non-mydriatic fundus cameras that can be used. We have lenses, indirect lenses that can be used along with the slit lamp, like a 90D or a 78D. You have a whole range available within this. And they can also be used to see the fundus. And of course, if you are having an access in a tertiary care center to all the mydriatic devices, from an indirect ophthalmoscope to fundus cameras, you can definitely use them. But in a primary eye care setup, I think a direct ophthalmoscope 90D and a non-mydriatic fundus camera all do a very, very good job of screening. So you have a lot of choice. The reason why I put a disclaimer on my title slide was I am not promoting any of these products, but just to give you an example that you have a lot of choice available today, from mobile-based interfaces to cameras that can be connected and photographed and so on. So I've got two short videos here to show you how effectively a direct ophthalmoscope and a 90D lens can be used to evaluate the retina. Okay, so I'm going to play this video. If you can hear it, if you cannot hear it, you can tell me. I can raise the volume. Arshada, is it audible?
Yes, ma'am, it's audible.
Okay, great. You can see the disc here being shown. Okay, so this was using an indirect technique which can be done in a primary eye care setup where you have an access to a slit lamp with a handheld lens. Although it's an indirect method, you can do it with mid-dilated pupils. Of course, if you're able to dilate, your view is going to be much, much better. The key thing you need to remember is that this is a virtual and laterally inverted image. When you're looking through an indirect ophthalmoscope, either with a 90D or an indirect ophthalmoscope, but it's very good for stereopsis, very good for viewing the peripheral retina and the central retina. So when you compare it with a direct ophthalmoscope, the direct ophthalmoscope gives you very good magnification. But the beauty of this is it gives you a direct ophthalmoscope. Most of them give you an option to change and see even for slightly smaller pupils. So you would at least be able to do justice to evaluating the disc even with a reasonably small pupil if the media is clear. Okay, so if there is very dense cataract, then obviously there will be no view, or if the pupil is really small or myotic pupil, then you will have no view. But small pupils, if the rest of the media is clear, at least the disc will be visible. So it gives you very good magnification. It's very good if you're able to get the patient to fixate directly at the light. You can get a good foveal reflex. You will be able to assess the macula, and very good for intermediate if you want to look for media opacities. And key thing is this is a real image. It's how the eye is you see it, whereas in an indirect ophthalmoscope you're seeing a laterally inverted image. So I have a very, very short video on how you can do a direct ophthalmoscopy, and I'm sure this is a fairly useful one. This one is got an audio. So Harshada, you can help me here if the audio is it loud enough?
No, ma'am, we can't hear it.
Ask the patient to fix on a target in the distance.
Yeah,
your
now it's there. Yes.
Right eye to examine their right eye and your left for their left. Start with your feet close to the patient and lean back. Identify the fundal reflex and follow this, moving in on a path 10 to 15 degrees temporal on the horizontal. When you're close to the eye, the optic disc should come into view. Go in closer still, and you'll get a wider and more stable view. Comment on how distinct the margin of the disc is, colour of the neuroretinal rim, and the cup to disc ratio. Then look for other signs along the 4 major branches of the retinal vessels. Finish by asking the patient to look into the light to bring the centre of the macula, called the fovea, into view. In a non-dilated eye, this will cause the pupil to constrict and you will lose the view. In a dilated pupil, the fovea can be seen as a slightly darker zone with a pinpoint reflection. Repeat this examination on the other eye.
So that's how you can go back to viewing the disc. Once again, I probably need to swap my screen again. Go back to. Okay. So, as I said, the direct ophthalmoscope gives you very good magnification, and it gives you a good view of the macula, and it's a
Start with hand hygiene and introduce yourself. Confirm the identity of the patient, explain the examination, and gain consent to perform it. Initially, take a few seconds to observe both.
Sorry for this. Okay. All right. So, so as I said, it gives you very good assessment of the disc. So the key things we need to remember between these techniques is one gives you a direct image, the other gives you an indirect image. So if you remember when we were using the 90D video, when you wanted to view the superior portion, the patient was asked to look down, and the view was taken from top so that you're looking at the opposite side of the eye. So you would actually see a lateral and a horizontally flipped image. So once you have learned how to do this, okay, it takes a little bit of time to practice an ophthalmoscopy. I'm sure most of them would have learned, but the question is whether we are putting it to practice. So what are we looking inside it? So how are you going to go about doing your diagnosis? So when we look at the disc using either a 90D or a direct ophthalmoscope or even a fundus camera image, what are we looking for? Look for the cup disc ratio. Let's assume you're doing a glaucoma screening. So look at the vertical disc diameter, the vertical cup diameter and the vertical disc diameter, and look at the ratio of what this disc and the cup are holding. So if it's going to be covering the whole of the disc, then obviously if it's a scale of 1 to 10, then if it is going to cover 90% of the disc, then you know the cupping is going to look like this, and it's like a 0.9 kind of a cupping. Whereas if it's going to be like this, you know it's smaller, it is holding like 40 or 50% of the cup, then we know we measure it as a 0.4 of the cup compared to the disc, and so on. So we look for cupping when it comes to glaucoma. Similarly, when you're looking for other conditions, okay, like a diabetic retinopathy, first thing you need to learn to do is to look at a normal eye. Say you're looking at a fundus photo, or you're doing a direct ophthalmoscopic examination, look for your blood vessels, look for any abnormal changes. So once everything looks good, the retina will appear like this. But if the patient has complications, you'll start seeing abnormalities. What are the common abnormalities we would see? For example, in diabetic retinopathy, we would see microaneurysms. You would see hemorrhages. So you will see dot and blot hemorrhages, which are like little blood clots, which you would see. You would see soft exudates. Soft exudates would not have clear margins, whereas the hard exudates would have very sharp margins and they would appear like these little white spots. The soft ones will be areas of white with a brighter orangish red glow around it. So you start looking for these changes. It's good to have a grading scale or picture when you are initially trying to do it, which is what we tell all our students. There's no harm in having a reference scale with you. And you have a lot of standard grading scales available. So when you look, and whichever scale you use, most of them are approved scales and largely they are very, very similar. So if you are looking for early changes, you would just see a few hard exudates. If you're looking, and if you're not seeing blood vessels growing, newer blood vessels growing, and you're not seeing too many microaneurysms, then it is a non-proliferative diabetic retinopathy. But if the patient is showing a lot of dot and blot hemorrhages, a lot of microaneurysms, and you're seeing large hemorrhages, multiple hemorrhages, then it's beginning to proliferate, and so on. And the most severe ones is obviously you would see more exudates, you will see vitreous hemorrhages, and so on, which will actually help you to know that this is an extensively affected eye with diabetes, and the patient needs to be referred. The next common condition we see is a age-related macular degeneration. Now, what are we seeing in an aging eye? Now, why ARMD is going to become a very, very important condition for us for future is we are seeing a lot more patients living longer, right? Earlier, we would see patients in their 65s and their 70s, and today very often in our practices, we see patients who are 80, 85, they're pretty mobile, they come walking in, maybe with some assistance, but they still want to be active, they want to read, they want to use their mobile phones, they want to take their own medication, and so on. So age-related macular degeneration is going to become a very, very common condition which we are going to deal with. Already in the developing world, besides diabetic retinopathy, ARMD is the next leading cause for blindness. So what do we look for in an ARMD case? So if you're seeing normal aging changes, then you will see very, very fine drusen, lesser than 63 microns, or just very fine drusen around the macular area. For me, I think the vision is more significant at that stage. If the patient with good light, with full ad is able to read an N6 font, I'm very happy with that eye. I just tell them to remain healthy and to keep coming back for routine checks. Now, if you start seeing early macular changes, then you start seeing more extensive drusen around the macular area. And here, typically, even if the vision is not so affected, the patient will complain of difficulty when the illumination is less. These patients do generally well with a stepped up ad, maybe from a 275, 250 to maybe a 350 ad. You don't see very significant changes on an Amsler grid symptomatically, but you do start seeing changes on the retina. That's your warning sign. These patients need to be monitored more carefully. By the time you move to a moderate or an intermediate AMD, you would start seeing more larger drusens, more vision loss, and more complications. The patient's more symptomatic. Now, that's a stage we need to monitor them more carefully, because there is a 25% chance that these, from a dry age-related macular degeneration, can progress to a wet one. And that's the point of referral. So once the evaluation is done, whether you're measuring a cup disc ratio, or you are measuring or looking for changes in a diabetic eye, or you're grading the macula for age-related changes, what is your next action, right? We need to know what we need to do. So once you measure cupping, there is a very laid down criteria for glaucoma. If you're seeing a vertical cup disc ratio, okay, so that's the reason why I showed you the image. There is a vertical disc diameter, and there is a horizontal disc diameter. So the vertical one is more important from a glaucoma perspective. So if you see a cup disc ratio which is more than 0.4 mm, that's a suspicious one. Now, even in high myopes, you will see large cup. But remember, physiological cupping is a diagnosis by elimination. Every high myope with a large cup is a glaucoma suspect, because we know the high risk for glaucoma. Myopes have a high risk for glaucoma. Next, you would see blood vessels on the disc rim. You could see like a splinter hemorrhage. You could see the curving of the blood vessels. You can see the way these blood vessels are being pushed onto the rim. So you could see that. And then if you find a difference of cupping, you could have a 0.1 cupping in one eye and a 0.3 or a 0.4 in the other eye. Now 4 is on the edge, right? But the difference between the two eyes is significant, then something is going wrong with this eye, right? So they again need to be referred. So what happens when they get referred? When the patient gets referred, they will go through a full diagnostic test, which will include OCTs, RNFL thickness, pachymetry, diurnal variation for intraocular pressures. Let the glaucoma specialist decide whether the patient has glaucoma or not. The key thing is you need to refer when you find any of these. Next, what do you do with the ARMDs? If it's early and intermediate stages, it's just wait and watch. We observe, right? Give the patient an home Amsler test. Give it to the patient, teach them how to do the test, self-administration, look for any metamorphopsia, and tell them to do it every day when they wake up in the morning, post their breakfast, at the end of the day, whenever they find half a minute to look at it, to stick it somewhere. My favorite place is I tell them you can put it by the mirror you're getting dressed, or you can put it on your refrigerator with your bound to open at least once a day. Quickly cover the eye and look at it. If you don't see any metamorphopsia, fine, just come back for six monthly evaluations. The day you find any distortion, please come back immediately, which means that's a warning sign if the retina is moving, if the macula is moving from a dry ARMD to a wet ARMD. Otherwise, the patient's more concerned about their vision not being very good for reading, their reading speed is lower, they're not able to go ahead with their routine work, like reading a newspaper or trying to read a medicine label and so on. Give them their high ads, give them magnifiers, give them better lighting. Most of these patients will symptomatically do very well. The day you see a wet ARMD is the day the patient needs to be referred immediately to a retina specialist, because once the health checks are done, everything is good, the patient will be taken for an anti-VEGF treatment, which will bring down the edema, right? So that's something which is a point of action for referral. Similarly, for diabetic retinopathy, you can use any grading scales. You have a lot of referral criteria. NIH keeps changing this criteria, but basically, I would think for background and non-proliferative diabetic retinopathy, first thing we need to tell the patient is to keep their sugars under control and come back for routine examinations. The day you start seeing the dot and blot hemorrhages, the neovascularization, the microaneurysms, that's when we need to start referring the patient. And when it's a diabetic maculopathy, diabetic macular edema, that's an emergency. The patient needs to be referred ASAP, right? So what's the point of action? When you examine the eye, you found an abnormality, this is largely the point of action which you should take for at least leading causes of blindness. So besides these, we also have other conditions which can be sight-threatening. So when you evaluate the disc, you could see macular edema. You could pick up macular edema for CSRs, for other conditions of CMEs. You can pick up branch retinal vein occlusion. So a lot of occlusive diseases, especially central vein occlusion, central retinal artery occlusions can all be sight-threatening. So these are the signs which you would see when you evaluate even a very highly myopic fundus. If you find that everything is good with the eye, but if you know that they are at the risk of degeneration, lattice detachments, then these are eyes that need to be more frequently examined. But if you find conditions like papilledema, it's an emergency and the patient needs to be referred. So these are some of the sight-threatening conditions which you can actually pick up while doing retinal evaluation. But fortunately, these are conditions which are a little more symptomatic. The patient will have loss of vision. They will come back with severe headaches, with less vision at night time, flashes, floaters, so on. But when we talk of glaucoma or early diabetic retinopathy, it's largely asymptomatic. So I think that's where the significance of picking up these conditions earlier is more vital. So what can you do if you're sitting in a remote practice, right? Today we have a lot of technology in our hands. What can we do? You can send your images on WhatsApp. You can send the images on an email. You can have a live call with the nearest retina specialist saying, this is what I'm seeing in the eye. Do you want me to send this patient immediately to you, right? So you can do phone calls. You can send images on WhatsApp. You can send images on email. You can use other telemedicine platforms where simultaneously, if you're in a remote location and have good internet access, you can simultaneously get your base hospital whom you have connected with to see the images and help you go on with the diagnosis. There are a lot of AI tools. Today, artificial intelligence is like a buzzword. So you have a lot of AI tools and algorithms built into a system which will actually help you do the grading. So you can use those in the initial formative times of when you're learning to do diagnosis. At the end of the day, I think the key objective is the patient gets care and early detection. I always tell this to my students. When the patient turns presbyopic, he does not go to an ophthalmologist. He or she does not consult an ophthalmologist. They go to the nearest optometrist. And every patient who's above the age of 40 has got risk for glaucoma. Almost 1 out of our 10, 50-year-olds are diabetic today, right? And we are seeing a whole lot of age-related patients in our practice. Almost every other patient needs a retinal examination. Then when it comes to your younger population, we are seeing a lot of myopes, and we know that myopes have, again, changes in the retina. So repeatedly, primary care is evolving around all of these, and retinal examination should be an important part of our eye exams. So coming to one of the cases, when I started doing retinal exams in my private practice. So when you are largely spending your day in a tertiary care center like ours at Lotus Eye Hospital, you have the freedom of getting a retinal consultant with you all the time, available like a 24/7 access. But when you're sitting in a private practice, so incidentally, my private practice is in a very, very remote area in a satellite city of Mumbai. And when I started doing retinal exams, this was one of the cases which I found very, very gratifying. She was a 28-year-old female with no remarkable medical history. She was healthy. She had just come in for a routine eye examination. She was a myo. Her office, she was an IT specialist. Her office was sending her for a 3-month project to the United States. And she said, I just thought I'll have a routine eye exam and pick up a new pair of glasses. So she was a myo with just minus 1.5 diopters. These are like the regular young myopes who walk into your practice. Nothing to worry about. 28, you're not worried about myopia progression. You're not thinking of pathological myopia. You're generally not thinking of anything going wrong anywhere in the eye. Her vision was 6/12, 6/6, not improving. So not improving with pinhole. Initially, I thought maybe some meridonial, some astigmatism. Let me, refractor, let me check what's going on with the eye. So I thought maybe she started wearing glasses a little late. Maybe the other eye developed myopia later on. So I asked her, just generally thought it could be an amblyopic eye. Again, less chances because the near vision in an amblyopic low myope is always very good. Something was not right. It was like a red flag to me. So I said, okay. I again asked her, I said, any family history of any ocular problems? Because initially she said, no family history of this, no problem, that, this. So I said, okay, fine. She said, my mother has problem with one eye, but I really don't know what it is. But I know she can't see very well with one. So, okay, now that was a second red flag for me. And I go ahead and do her fundus photography. And this is what I see. So what do you think this is? Anybody from the participants would like to respond what this is? Give it a try. It's not an exam. Can they hear me, Harshada?
Yes, ma'am.
Okay.
I think we have, people are saying disc coloboma, RD.
Okay. So, yes, it looks an abnormal disc. So if it's a disc coloboma, it still doesn't explain the vision to be so good, right? 6/12. So even I thought it looked like some congenital disc issue. But the most disturbing thing was those weird blood vessels on the disc, right? In a coloboma, you don't see active blood vessels growing here. So I knew this is not sounding good. I sent the retinal images to a retina specialist. He also thought this doesn't look good news. And when the patient was eventually, the diagnosis was done, the patient had a retinal capillary hemangioma. So MRIs were done, and eventually Dr. Santosh Honavar treated her with PDT. Fortunately, did not metastasize. They managed to save most of her vision in that eye. And generally, this was not a cancer which was spreading, but definitely it was very scary. If this image would not have been done, I'm sure by the time we would have picked up the condition, we would have lost all the vision in that eye, right? So I think this was one of my most gratifying cases. This was way back in 2016. I could tell you a lot more stories of cases we picked up earlier, just doing fundus photography. I picked up a lot of cases, even just doing a direct ophthalmoscopy and identifying them with glaucoma and so on. So I think it's very, very gratifying that even if you can save vision for a few people by picking them up early, I think it's worth doing a good retinal evaluation. So I'd like to stop here. Thank Optometry Council of India, Vision2020, and Lotus College, of course, for permitting me to be here and give this talk, and for CyberSight for hosting this. Thank you so much. If there are any questions, we can take it.
Okay, just regarding the fundus evaluation, which many of us actually in a private practice, I would say a lot of us actually ignore. Once we have achieved a good vision, and then you've addressed his basic or a chief complaint, whatever he has visited you, most of us as practitioners actually just let go, and we don't really pay too much attention. What I would advise to a lot of interns, people who have joined the hospitals or primary eye care centers, I would still say, though many of them may not have enough time or they don't give an opportunity for them to evaluate or do a fundus evaluation, please carry your direct ophthalmoscope with you and take a quick look into the eye. It doesn't take more than 2 minutes. First of all, learn to evaluate a normal fundus, and then you take it over to the next level, trying to understand, okay, this is what I saw, then I go back and read up. So these are small things, but it is very useful and very helpful in the future when you are actually getting into a routine private practice. Okay, here I would just like to present to you one case which I had seen just last year, and this happened to be our maid servant's daughter. She's an 18-year-old female, basically a domestic worker. On 4th of October, since she came home, she was complaining about the pain in the left eye since 2 days, which is worsening since then. Actually, otherwise, when we get these kind of cases, the first thing ask is there a problem with your vision? And they say no, and you try to ignore it because they're trying to seek some attention. So, but then she insisted that her pain is getting worse. And on 6th of October 22 is when I said, please come over to the clinic. Let me take a quick look into the eye. Her unaided visual acuity was 6.6 in the right eye, and the left eye had about 6.12. With a little effort that she was trying to guess and read, the image did appear distorted to her. She said, it's not very clear. Only a few alphabets was read on the Snellen's chart. Slit lamp examination when done, absolutely no problems. The pupil response was normal. It is when I did the direct ophthalmoscopy and looked into it, normal central fundus in the right eye, but the left one did show normal optic nerve head region. Okay, and then when I moved on to the macular area, there was a slightly darker and elevated zone or an area, but this patient was not cooperating due to the pain that she was experiencing. So I just calmed her down and I said, she just kept cribbing and said, no, I can't take it. All right. And then I just said, let me take an image in this particular case. So this was the image taken by the retinal imaging system that I have. The right one is showing absolutely no changes, no problems. And of course, whatever you see here, the white light around the macular area is basically seen in most of the young children. It's the reflection of a very, very shiny retinal surface. What I saw on the left was a slightly darker area, the macular area not being very clear. And then secondly, also this elevated area, which didn't look very healthy at all. So what I'm trying to say is just pick up something abnormal. You know, there's nothing much that we can do once you spot these kind of changes. But then I had to take a call and saying, okay, this person needs an urgent or an immediate attention, for which I referred this to a retinal specialist on the same day to the closest person who is around. Of course, he was available, and my guess on that case was toxoplasmosis. So I called him, I said, look, doctor, I've got this case, I'm suspecting toxoplasmosis, but just take a look into it. On the first visit to the retinal specialist, his diagnosis was viral retinitis, and I have no clue why he had decided that or diagnosed that. But then he had also suspected toxoplasmosis, I guess, and he subjected this kid for a few tests on the blood reports. Once that came up and it was confirmed, the toxoplasmosis was the positive and the right diagnosis. Well, over a period of time, the doctor did manage with oral steroids just to bring down the inflammatory changes and also manage the toxoplasmosis. What should be brought to attention here is, imagine what may have happened if the ophthalmoscopy was not done. If you just said, okay, I don't understand what the problem is, I think you should go and see a general physician. A lot of us do hesitate to send them to an eye hospital or another ophthalmologist because you think everything is all right. So just go ahead and see a general physician. I don't think most of the general physicians around today actually do any bit of ophthalmoscopy. Anyways, what is important here is that refer the patient to the right specialist for the fastest treatment. Now, what I have done here, I'm very happy, is that I have referred this case to the retinal specialist who picked up the problem, started the treatment immediately, and then also parallelly had the blood tests done, confirmed the diagnosis, managed it fairly well, and the problem began to subside pretty quickly. Yep. And the next follow-up which I did was on 10th December. And yes, there was a lot of changes that I could see on the retina of the left eye. It had resolved quite well. Her 612 visual acuity had come down to about, or improved to 6.9, and hardly any distortions. The pain was completely gone, right? So this is something that's important for you all to note, that just doing a simple direct ophthalmoscopy, you may not have to do the 90D lens, but if you have access to all of it, please keep practicing. In direct ophthalmoscopy, please practice, okay? But then if you just do a direct ophthalmoscopy, you can pick up a lot of these cases with diabetic retinopathy changes. I've seen a lot of changes related to papilledema, and referring them on time is the most important thing. Early diagnosis and referrals are important. And as Prema had rightly put up some charts out there as to what next, that's a very, very important slide. I think you guys should have and follow it through. Yeah, that's about from me.
Yeah, thank you, sir. Thank you for the advice. Kunal, sir, would you like to share your experience?
Yeah, thanks, Arshada. And thank you, OCI, for inviting me as a panelist. So I would echo the lot of thoughts which Dr. Prema Chande has shared. So let me tell you, we have an optical setup, And a lot of times we actually get patients who just come for a simple refraction, but all of you would agree, it is much more than the refraction that is should be there in the clinic. And let me give you a few examples. So we regularly get patients who come for refraction. And here was a gentleman who came for a refraction where we found out the visual acuity was 6/24 in one eye, and the other eye has 6/9. We asked the history and all, so he basically never had any case of any injury, or he was diagnosed as a diabetic patient. And then we went with the refraction. So with the pinhole, there was no improvement. And the moment we did the fundoscopy, we could find out it was basically a case of proliferative diabetic retinopathy, which the patient was absolutely not aware of. And a lot of times you basically catch those cases. And if you look at all these patients, right, don't want to go to an ophthalm because they feel it will take a lot of time because their eyes get dilated. So they go to an optometrist or a nearby optician just to get their eyes examined, thinking that it will happen very fast. So when you do a fundoscopy, you can catch hold of all these cases at a very early age. And not only that, once you show to the patient, right, that you have got a diabetic retinopathy, so the patient also starts becoming serious. After that, they take care of the eyes. So that is the reason why it is part of the duty to not only get the refraction done, but also the retinal evaluation done. So I would recommend everyone, anybody who walks into your clinic, you should at least get a direct ophthalmoscopy done. And let me tell you, we also have a non-mydriatic fundus camera, and how it has changed all of you would agree that technology has changed majorly, and it has changed the way the optometric setup looks right now. So I had another case, a good friend of mine, who basically called me in the early morning that he feels his vision is lost in the one eye. And we immediately called him to the clinic, and we saw that his vision was, he had a normal vision of 6/6. On the torch examination, we found out that he had an RAPD in the right eye. And on the fundus examination, he basically had a papillary edema. So what we did was, we immediately sent the picture to the retinal specialist. And within an hour, actually, the retinal specialist looked at him, and he was basically diagnosed with optic neuritis. So they immediately started the steroidal treatment. So you can imagine sometimes this times becomes very crucial. And when you have a technology, I think you can address the problem very quickly, much before you can much anticipate otherwise. So my take would be to invest also on the technology, because that really helps. Over to you, Arshita.
Thank you, sir. Thank you for sharing your experience. I would like to ask you, all of you, that, since you all are running your private practice and successfully, so we want to know how incorporating a retinal evaluation or fundus evaluation in your private practice, being an optometrist, has helped you to build or grow your practice over these years. Or rather, I would reframe that, what would you advise all these young practitioners about, incorporating fundus evaluation in their practice? Yeah, ma'am, would you like to go first?
Yes, I think from a practice builder, it's a short practice builder. You invest on your machine. You have very, very low cost machines available today. I'm sure Ajay, and when we started fundus cameras, they were far more expensive than what they are today. Today you have a lot of mobile interface devices which are way cheaper, and it's a worthwhile investment. And you will definitely recoup your money back because it's a pay-per-use. Models are also available, and you're going to charge your patient for doing a retinal examination, right? But I think it's not about the return on investment. For me, the practice builder is the faith the patient has in you. You can imagine when the patient knows that this is the best place to get an advice from. Even if the ophthalmologist is treating them, they still want to come back to you to make sure that they are getting the right advice. And I think that's the most gratifying thing for me when I have patients who would even travel all over the world, but still want to come back to me for their eye exam. They not only come, they also refer patients to you. Their entire family comes to you. Their friends come to you, because I think that's how you build your practice. And I think that's definitely a practice builder. And of course, if finance is a question, then repeatedly Kunal and Ajay sir have both said that a direct ophthalmoscope also can do a lot of justice, right? And that's definitely not, it's just an extra head on your retinoscope, which doesn't cost you money. So I think that's definitely something. So every patient who's a presbyo, I think that's something which we have really grounded even our students. I don't know how many of them go out and practice, but we emphasize on them that when you do a complete vision screening, it's a good history, it's refraction, pupil evaluation, eye movements, because you're looking for neurological issues and so on, and you end with a direct ophthalmoscope. So I think that's very, very important. So if you can't buy a fundus camera for the time being, you can at least do an ophthalmoscope. When you can invest on a fundus viewing tool, irrespective of what it is, go ahead and do it. It's a very good practice builder.
Ajay sir, would you like to comment on this?
Yes. With regards to building a practice, I would say, first of all, in a private practice, I will insist that the person or the optometrist explains to the patient exactly what are the procedures he's running it through. All right. So once first you start the slit lamp examination, then you tell him you're assessing the anterior half of the eye, and then you do a refractions. They know exactly what you're doing. But when you're doing a direct ophthalmoscopy, you do tell the patient that you will be seeing the posterior half of the eye. So yes, in the initial stages, they may not be able to understand what you're trying to explain. But then if you have a chart or an image of the retina, telling him, hey, look, these are the things that I've actually assessed in you, and these are the structures I've evaluated in your eye. All these are normal, or if you found any changes, do express to them. Educate a little bit about the tests that you have done. Of course, it adds value when you have a fundus camera, and then you can show the image, explain the retinal image of the patient to him, and which is very, very satisfying that he's come to the right place for a comprehensive eye examination. Yep.
That's right. Okay, we'll take few questions. We may not be able to take all the questions because of the time constraints, but we'll try. Okay, any investigation procedures to differentiate between glaucomatous disc changes or the changes due to the optic disc coloboma or pit?
At the end of the day, you will, when you are doing a fundus evaluation using an ophthalmoscope or a fundus photo, it's only going to tell you that this is an abnormal disc, the abnormality coupling which you are seeing. Like how I said, even a high myope will have a 0.6 coupling, right? But you have to go ahead with a complete diagnosis, which will include OCTs, retinal nerve fiber layer evaluation, and so on. And after that is when you can actually arrive with a full diagnosis. So even the case I shared, the disc looked very, very abnormal even to the general ophthalmologist who was close by. Eventually, the MRI and all the other tests helped us come up with the diagnosis of a hemangioma. So that's something which, as optometrists, you need to understand that we can identify an abnormal eye, we can screen, we can come up with a tentative diagnosis. Even ophthalmologists come up with a tentative diagnosis initially, like a suspected glaucoma, a suspected toxoplasmosis is what Ajay sir shared. The first reaction of the ophthalmologist was a viral. So we knew this is inflammation. We knew this is acute. right? We knew that. So you're already picking up some signs. Final diagnosis can come after doing more tests. So that's what I would put on to. And then, of course, if you're talking about a coloboma, you're looking at age, you're looking at other things, you're looking at history, which will give you an indication whether this is a coloboma. So you just don't see a coloboma. You would see a lot of other things that would be with it, right? So especially in colobomas, you would see nystagmus, the vision's not developed, you may see it in both eyes. So a lot of other indicators are there to help you do the diagnosis. So I think the key at this point is to know what is normal, what is abnormal at primary care. The moment you pick up the abnormality and then you refer. There's one question in the chat box which I would like to answer, Harshada.
Yes, ma'am. It's how to treat BRVO and CSR, early stages. Yeah.
Early stages. I think the most important thing is, see, with the BRVO, most patients, almost 65–70% of them turn around in 3 to 4 weeks. Some of the vision comes back. I think it's not about what damage it's done to the eye, but why that has happened. Most cases, occlusive is BRVOs. Most occlusive is either hypertension or inflammation. The inflammation could be because of diabetes, it can be because of COVID. Now we're seeing a lot of occlusive conditions coming post-COVID, post-vaccine. We don't know what the inflammation is because of, right? So inflammation can give you two things. It can either give you an aneurysm or ischemia, right? So if it's within the blood vessel walls, it's going to give you that blockage and it's going to give you that ischemia, which you would typically see in CRVOs, BRVOs. So I think that's my red flag. Something is going wrong systemically and this patient needs to be referred, right? Let them go through the investigations. I've had patients with subconjunctival hemorrhages having extremely high blood pressures and literally getting hospitalized, and we pick them up and saying, listen, something is not right. Don't worry about the eye. Go back and look at your blood pressures, right? So I think that's the red flag. We should look out for these red flags as primary eye care practitioners. We are the gatekeepers of your vision, and they've come to us. Do what you think is the best for that eye and explain to the patient what you're seeing, why you want them to go for tests, and so on.
Okay. Thank you so much, ma'am. We'll take the last question and we'll end the session. Okay, how to correlate retinal evaluation with visual acuity when you don't have any tools in your clinic? So how do you correlate it? Yeah. Kunal sir, would you like to answer?
Yeah. So basically things are very simple. I mean, you use your pinhole that is easily available. If there is no improvement with your pinhole, that should be your thing which should catch your attention immediately. And you should refer all these cases till it is proven that it is an amblyopia case. So I always do in that way.
No media opacities. If the
no media opacity, yes.
Also check the old records.
Yeah.
Yes.
They also check the old records to understand. Yeah, that's important. What was the quality of his vision in the past?
Earlier.
Yeah. You can use your retinoscope, which is easily available. So you can see the media opacity pretty comfortably with that.
Yeah.
I think I also do a lot of Amsler. I give a lot of weight to the simplest test, but I think it's a great test for doing macular function.
Yeah.
All right. Yeah. So thank you all for giving your valuable time, and thank you so much, Prema ma'am, Ajay sir, Kunal sir, for participating in this session. We'll be having next session on low vision at the end of the October. So as we fix speakers and panelists for those, we'll share that news with you. Thank you so much all. If you have any queries regarding registrations or any membership related issues, you can always reach to us on info@optometrycouncilofindia.org. I'll put the link in the chat box. Thank you so much. Thank you, Prema ma'am, Kunal sir, Ajay sir, for joining.
Thank you very much.
Thank you so much.